Thank you. So post-lunch is always a tough time to start. People are just digesting their food, so I'll try to be brief. Can I have the slides? If whoever is there can give me the slides. Okay, so first of all, the topic is very interesting. It took me a lot of time to understand that Dacomitinib is supposed to be Dacomitinib, which I'm supposed to be talking about. So my talk is on Osimertinib versus Dacomitinib. It's a slightly difficult topic to talk on without showing any of my slides, but I will try to do that. Now, we have been discussing about EGFR and EGFR positive mutations for the last, I think, several years. And it was a bit shocking for me when I tried to read up this topic that I discovered that last 1 year, there has been really nothing much happening in first line. So I will just talk of the data that is existing already for Osimertinib and Dacomitinib. Now, Osimertinib, the phase 3 trial is the FLORA trial. Now, FLORA was a trial designed to look at the PFS and the OS. The primary endpoint was PFS, in which overall the PFS was 18 months versus 10 months. So Osimertinib versus first generation Geftinib or Erlotinib showed a benefit of around 8 months. Interestingly, when the overall survival data came, it was positive, around 37 to 38 months versus 33 to 34. But the hazard ratio was just in kissing distance of your unity. So we had almost 0.997 the confidence interval. Still a positive trial, but the subset analysis, when we looked at, that was again kind of interesting because the subset analysis showed that your exon 19 deletion was definitely positive. However, the exon, the L858R did not show a positive response. So that was what was about the Osimertinib final analysis. Now, you could argue that the end result was still there. There was more like 4 patients were alive in 2 and 3 years. So the overall survival advantage could not be denied. It was there. So next came up the other trials. We had the Dacomitinib trial, which was the Archer trial. Now, the Archer trial actually was meant to be in the first line. Again, they introduced Dacomitinib versus Gefitinib alone. Interestingly, they did not include any patients with lung cancer, with CNS mets. So that was something unusual. CNS mets were not included at all. And the primary endpoint was again a PFS. So that was something different from these two trials. What it showed is that the PFS was met, 14 versus 9.2, a little not so impressive in terms of number. Whereas in the FLORA, you had a slightly better result. It was 18.9 months. When the final overall results came, for Archer, there was no statistical significance. Absolute amount also 34 versus 26.8. The trial design was such that it did not really look at the formal OS, but still it was not really significant. Whereas, of course, in the FLORA, it was significant. So coming to L858R alone, FLORA, no OS benefit. Whereas in Archer, when they specifically looked at the L858R, it was statistically significant. What are the other options? EGFR TKI plus VEGF. So you have a EGFR VEGF access. So you have Ramucirumab Erlotinib, or you have the Erlotinib Bevacizumab. Both the places found to have a benefit in terms of the PFS. How the final OS, however, was not met. So again, EGFR plus chemotherapy, plenty of trials, including our own TMH trial, which showed both PFS and OS advantage. Again, the absolute numbers were not as high as Osimertinib for various reasons, which we have all discussed prior to this. And however, what they saw is other trials have not really shown a benefit in terms of the overall survival. Everything at PFS advantage, but no OS advantage. So at the end of it, if I have to talk of a separate set of patients, the CNS patients, again in intracranial PFS and in intracranial overall survival, Osimertinib did have a benefit. So for me, this is the crux of what I will be doing today. If I have an EGFR positive, exon 19 deletion positive without CNS mets, Osimertinib has OS benefit. Chemo plus Gefitinib has OS benefit as per Indian data. Erlo-Bev, no OS advantage. Erlo-Ramu, the data is not yet out. So would I push for Osimertinib versus chemo-Gefitinib? It's easier to use Osimertinib. It is more expensive, but it is easier to use. If there is CNS mets, I would possibly pump only for Osimertinib. Again, the data of chemo-Gefitinib is there. Those patients were included, a few of them in the TMS trial, though I am not aware of the exact final results of that. When you look at exon 20 insertion, we already had a session on that. We mostly chemo followed by amivantamab. L858R, no CNS mets. Dacomitinib is an option because of its OS. Erlo Ramu, Erlo Bev, Osimertinib, all have PFS advantage. Strictly speaking, no OS advantage. Would we still push for it? It is still a good option. What about the CNS mets? Again, only Osimertinib. So by and large, Osimertinib seems to be the winner, at least when it comes to single agent TKIs. Rare mutations is, of course, a different agent. So as far as I am concerned, Osimertinib seems to be the king as of now. Till further evidence, this is where we are today. So thank you very much.